That's right, change. One word that can be both negative and positive. Surgery has been an endless wave of change that has helped us become more informed, has led to a better outcomes for our patients, and helped us grow as a surgical community.
When we look back, say on the last 20 years, change can be both small, which has evolved into what we know as standard today, or change can be major, something having been forced upon us that we never would have expected.
As surgeons right now, we have an opportunity to be able to review what we're doing, to reflect, to question, and to adapt parts of our practice so we are better.
After all, that's why we became surgeons, right? And yes, we know that change takes longer,
Feels uncomfortable,
takes effort.
But that is why as a community we can persevere, and each one of us can make small changes to make a big difference.
My name's Jared Torkington. I'm a colorectal surgeon in Cardiff. I'm joined by three friends, and we're going to be talking about incisional hernia prevention, colorectal surgery, and the difficulties of introducing change into the OR. So we'll go around and we'll briefly introduce ourselves. Hobart, perhaps you'd like to go first.
Thank you, Jared. My name is Hobart Harris. I'm joining you from San Francisco, where I'm on faculty at the University of California. My practice is a combination of abdominal wall reconstruction, some hepatobiliary and pancreas, and then, of course, acute care surgery.
Eva?
Hi, my name is Eva Derenberg. I'm joining you from Rotterdam, the Netherlands. I just started working as a surgeon here again after I did a complex abdominal wall reconstruction fellowship at CMC in Carolinas, in Charlotte. And I work mainly do mainly colorectal procedures and abdominal wall reconstruction.
Thank you. And Maria?
Hi, I'm Mario Boermeester. I'm a surgeon in the Amsterdam University Medical Center's location AMC. And my practice is intestinal failure surgery, complex abdominal wall repairs, and a bit of HPB surgery during acute and chronic pancreatitis surgery.
So let's do this. Today, our panel and a few familiar faces will discuss how we can make a small change that could make a big difference. Because I hope you agree, prevention is better than cure. Before COVID-19, when was the last time you introduced a significant technical change into your surgical practice?
Well, I think the last time was maybe 2 or 3 months ago. And as you know, we have a very active traveling unit. So my colleagues, and myself as well, we bring back things we have seen. And what we changed was the way we make the purse string. To do a circular stapler anastomosis.
Before COVID-19, I think the biggest change was about 8 years ago when we started to use the small stitch technique to close the laparotomy wounds. And that was the biggest change.
I think the most important thing is to look at the prevention. So that means to have prophylactic mesh implantation in patients at risk, as already mentioned.
That was a result of the heart study. So I have used the Hughes repair and still continue to do so for patients who are high risk of incisional hernias, particularly the emergency patients.
Let's come on then to actual prevention then. Ava, you're probably responsible for the most significant paper in this field, really, in terms of, a paper 4 or 5 years ago now in the Lancet of small stitch. And what is your perception about adoption of small stitch following that paper?
It's difficult for people to change. Especially the younger surgeons are more willing to change because they're still used to, I think, seeing different techniques from different surgeons, adopting things in their learning curve. So they're easily to try something. But some older surgeons that try the technique and then have a complication with it because they didn't apply correctly, or don't know why, they immediately fell back to their old practice. Like, no, I tried it, it didn't work, didn't like it. That's really hard, but the more and more people are using it, the more trainees are getting trained in it, and then it's really spreading. And then in America, always the argument was that the patients were obese, so they couldn't apply my technique, which is not true, because we had patients with BMI up to 50 in the stitch trial. But as was pointed out of one of my friends in the UK, Neil Smart, he said the Lancet publishes the interquartile ranges. So the interquartile range was 22 to 27, the BMI in the stitch trial. So people in America all feel like there were only people with BMIs up to 27 in the study, but that's not true.
Okay, because it strikes me, Hobart, it's not had a great deal of traction in the States.
No, very little traction whatsoever. And when I'm speaking locally and when I get the opportunity regionally, I always draw a comparison between the level of evidence and scrutiny that my colleagues apply to utilizing this closure technique versus their use of the robot. The evidence, cost, time associated with using the robot to fix hernias, is almost indefensible from my perspective, but yet no one seems to challenge that. But when you ask them to simply use a technique that has been studied and there's strong evidence over decades that it reduces a very common problem, you hear all sorts of excuses, including this excuse about BMI. Furthermore, to me, the fundamental issue here is one of wound healing. And I don't know of any documented evidence that people with a BMI over 30 demonstrate a different process of wound healing than those with a BMI under 30. I think that there's just a very entrenched perspective, but also there's just no compelling incentive for people to change their behavior. And evidence alone will not do it.
Well, that's an interesting statement. What do you think about that, Maria? Evidence alone won't do it.
Well, in a sense that it means you can wave your evidence in front of somebody's nose, but there's more to it to really implement that in practice. Surgeons don't like to change their practice. My philosophy is that some of us do because we like to innovate and we like to do research, but others who've been practicing a certain technique for 10 or 20 years, if you tell them, but actually that is not good what you're doing, there's a better technique. If you flip it around, you're saying the things that I've been doing years is not good enough.
What would you say, Hobart? I mean, in your unit, does everybody do a pancreatectomy the same way?
The United States is the Wild West. There is just incredible spectrum of practice within the same unit, within the same hospital, let alone between hospitals or between states or regions. No, and it's very, very hard to standardize. And part of that is the strong sense of independence that I think many surgeons worldwide feel and appreciate.
What, in your opinion, stops surgeons changing their operative practice on the basis of new or emerging evidence?
In my group, the traditional implementation of novel clinical adoption of novel clinical techniques or even of practice is basically usually very spontaneously proposed by some articles or by some talk that we have seen at the meeting.
Two reasons. If they think they have a good running system, they won't change. That's the one thing. The second thing is if they are not aware that there could be better things. And the third thing probably is that the change process is too difficult for them, so they stop.
Probably bloody-mindedness. Well, I think people get comfortable with what they do, and it's a big step to change and think outside the box and adopt something new. And I think a lot of us are quite conservative.
I'd say the biggest barriers are people's personal beliefs, which can actually override evidence that their own results aren't particularly good, evidence that their results could be improved, evidence that there is a different technique that's better. But if you've got a technique that works for you, then you don't really want to change it. A bit like an athlete who wins a race wearing a yellow sock never wants to change the yellow sock.
In these COVID pandemic times, we have been able to change quite a lot quite quickly, haven't we?
This is the motivation. I mean, you're absolutely right. People can change, but they have to be motivated. And COVID created a number of motivations that people were more than willing to respond to. I don't see hernia prevention ever approaching the same level of compulsion as COVID-19.
I believe in the prophylactic mesh, and I believe in prevention of SSI. And when I combine those and see it from the patient perspective and from the perspective of all the healthcare misery and healthcare costs, I think that's a great trigger for change. But the first step is usually that you have to change, like COVID made a clear statement that we had to change our practice.
So one of the big questions is, do we practice what we preach? If you guys were having an aortic aneurysm repair done openly, would you have a mesh put in, Hobart?
It all depends on who's going to place the mesh, but someone who is skilled, yes.
Ava?
Well, the argument that I'm going to live for another, hopefully 50 years, I think really makes a strong argument to get a mesh, because I don't want to be operated again for an incisional hernia or ever get a complication. But I agree with Hobart, preferably by a hernia surgeon put in.
Yeah, and I think so too. I agree with that. An incisional hernia after aortic aneurysm repair is a horrible thing. And these are patients that don't want another operation. So I think if it was me, I think I'd have a mesh. But let's see what our panel said.
If you were having aortic aneurysm surgery, would you have a mesh to prevent incisional hernia, or what evidence would you need to make that choice?
Yes, I would, because having a large laparotomy with a big incisional hernia has profound impacts on people's body image, their quality of life, their ability to move, their pain, and I'd want to avoid that.
We don't need any evidence. We have it already. Well, with the PRAMA trial and the PREMAT trial, both showing that the AAA patients should have in all these cases.
If I would be the patient, well, I think these guys, they have an incisional hernia rate maybe in between 20 and 25%, even much higher than after a midline in GI surgery. Then I probably would like to have a sublay mesh, yes.
Was recommended a lot of times, and I try to bring my vascular surgeons to the point to put a prophylactic mesh for AAA reconstructions.
So what can we conclude from today's presentation? Is it possible to change in the operating theatre? Well, of course it is. One of the things that we're committed to as surgeons is lifelong learning and improving our techniques, improving what we do to improve the lives of our patients. We've shown it during COVID, we'll continue to show it. So what does it require? It requires individuals to be inspired, to innovate, and to bring things forward. But it requires units to be prepared to look at their own data, to embrace and to encourage, and to take things forward. And I think perhaps the real message out of today is that we can't just change to do the sexy things. We have to do the things that perhaps matter most to patients, like preventing incisional hernias. So have a good look at your unit, talk to your colleagues, think about where your next change is coming from.